Sir, I just give you count. So we are starting in 3, 2, 1.
So, a good day, everyone. My name is Divyanshu. I'm representing the medical affairs team at Zydus. It's my privilege to welcome you all in this inaugural Master Stroke Symposium, an event dedicated to exploring the critical connections between heart and brain health. In this series, our goal is to shed light on the latest advancements and practice in preventing cardiovascular diseases. Today, we have compelling lineup starting with a keynote on modern approaches to screening and managing strokes in patients with AFib. Following the top, our panels of esteemed experts will share insights and their respective countries, discussing the nuances of treating such conditions in everyday clinical practice. I sincerely welcome each one of you to these enlightening sessions. Without further ado, let me introduce our distinguished speaker for today. He is a renowned electrophysiologist from India, Dr. Anil Saxena. Let me share my Yeah. So Dr. Anil Saxena is a senior consultant electrophysiologist, executive director cardiology Fortis, India. He is an internationally acknowledged speaker in the field of cardiac arrhythmia and electrophysiology. He is one of the most pioneer in implantation of ICD devices and biventricular pacemakers in India and has one of the largest experience in this field. He has been performing studies and ablation complex cardiac arrhythmias for over 30 years with thousands of successful procedures to his credit. So I welcome our today's speaker, Dr. Anil Saxena. Over to you, sir.
Thank you. Thank you, Divyanshu. It's indeed a pleasure to be here in this program today. And let me share my slides. So I'll be talking about stroke prevention and atrial fibrillation. How to choose a NOAC for stroke prevention. Now we know that atrial fibrillation is a very common disease, and we are experiencing a global epidemic of the sort. And as the population is aging, especially in the developing countries, as the population is aging, we are looking at a further rise in incidence and prevalence of atrial fibrillation. Now, there was a time about 20, 30 years ago when atrial fibrillation was just an appendage to diagnosis. We did not understand the risks associated with atrial fibrillation, but now we know that atrial fibrillation confers about 4 to 5 times risk of stroke compared to normal sinus rhythm. And in the older population, it can be considered to be a major cause of embolic stroke. The annualized risk of stroke is about 3% per year, but it varies widely among different persons. So it can be as low as 0.5% in some people with atrial fibrillation. It can be as high as 8 or 9% or 10% in annual risk in some other individuals. So we need to individualize the risk. One important thing to understand is that the risk is evenly distributed in silent and symptomatic atrial fibrillation, and that raises the importance of surveillance because unless we recognize atrial fibrillation, we cannot understand the risk or even do anything to modify that risk. So, regular intervention, regular surveillance is very important. Now, what happens in atrial fibrillation is that the atria do not contract the way they should normally, and that leads to stasis of blood in the left atrium, particularly in the appendage, and that leads to thrombus formation in many patients, which can then dislodge and migrate to the brain and cause a extensive stroke. What is unique about this cardioembolic stroke is that it is generally very severe. It's a large stroke because the clot is large, and it's quite often fatal. And even when the patients survive, they are often limited by disability. That's why most of the guidelines after the acute management, they focus even before the actual management of atrial fibrillation by rate control or rhythm control. Most of the guidelines today focus on anticoagulation. I mean, identifying the patients who need to be given anticoagulation. And because most patients need to be given anticoagulation, we actually have to identify patients who do not need to be given anticoagulation. So anticoagulation has now been understood and cannot be overemphasized that it's a very, very important therapy for patients with anticoagulation. Now, to know the stroke risk, we have several risk score systems. Initially, we had the CHADS scoring system, which is now superseded by CHADS-VASC scoring system, which is basically the dominant risk scoring system used across the world, and is also recommended by most of the guidelines as well, where we give points to different comorbidities, like congestive heart failure is given 1 point, hypertension is given 1 point, age more than 75 is given 2 points, and 65 to 74 is given 1 point. Diabetes mellitus and vascular disease including history of MI is given 1 point each, and stroke or TIA in the past is given 2 points. Female gender is given 1 point. So score can be from 0 to 9. Now, there are other scoring systems also which have their own advantages because many things are not covered in the CHADS-VASC score system. And the newer scoring systems are required, which also take into account various other factors like the LA size or renal dysfunction or some biomarkers or some genetic aspects, mitral calcification. So there are many, many other factors which are also associated with increased risk, but they're not part of CHADS-VASC. In fact, none of the scoring system is complete in every way. But Atria and Garfield, they offer some advantages. So our practice is that in patients who have a low CHADS-VASC score, for example, somebody has only 2 or 1, and where we are in doubt whether to give anticoagulation or not, we take the help of Garfield AI for atria score system and see what is the score coming and whether we should give anticoagulation or not. And we can guide the patient or help the patient take a more empowered decision. What is being increasingly understood is that there are so many factors which are responsible for stroke risk in atrial fibrillation, which could be atrial fibrillation subtypes like paroxysmal or persistent or permanent atrial fibrillation, the comorbidities which are part of the Church-Vasque scoring system, the left atrial substrate. Now, that is also not part of the Church-Vasque, but it is well understood that there could be some structural aberrations within the left atrium, which may lead to more thrombogenic atrial substrate. And like, for example, rheumatic heart disease patients have a pericarditis and they have a residual sequelae within the atria, which makes them particularly susceptible to thrombus formation. And the duration of atrial fibrillation, there was a time when it was like a binary thing, yes or no. But now we know that the duration of atrial fibrillation, the total time is spent in atrial fibrillation is also important. In other words, what we call arrhythmia burden. So it was very well understood in early 90s that anticoagulation is very important for reducing the risk of stroke in atrial fibrillation patients. And most patients used to receive warfarin, which has its own share of problems like monitoring is required, so many food and drug interactions. So there's been a lot of excitement over the last 2 decades in this field. And many novel anticoagulants were discovered like apixaban, rivaroxaban, edoxaban, and dabigatran. These are available in almost all geographies now, and they have been very well accepted and they have very good data with them. The main difference being that they are rapid in onset, the dosing is fixed, so we don't need to monitor them, very less food or drug interactions, and monitoring is not required. That's the most convenient thing for the patients and physicians. And of course, when we stop them, the offset is also short, so the effect goes off very quickly. Now, these are the prevalent guidelines that whenever we see a patient with atrial fibrillation, we first look whether the patient has a mechanical heart valve or not, or if the patient has moderate or severe mitral stenosis or not. If the patient doesn't has these things, then of course patient requires vitamin K antagonist, because we have seen that in this subset of population, NOACs are not a good choice. If the patient doesn't have these conditions, then we try to find the risk score. And like, for example, the Church-Vasque score, if the score is 0, then the patient doesn't need any anticoagulant or any antiplatelet, because the risk is supposed to be around 1 or less than 1%, which cannot be modified significantly by anticoagulants, and rather we will be increasing the risk of bleeding. If the stroke is 1, if the risk score is 1 in males or 2 in females, then we should consider anticoagulation by NOAC. And there again, we need to empower the patient, because it is that the risk is around 1.2 to 1.5%. And we can lower it by about 40-50% in this particular population. So we need to empower the patient to make a decision. If the risk is 2 or more, then certainly the patient requires anticoagulation. And now all the guidelines, they suggest that NOACs are preferred over vitamin K antagonists, although we can use vitamin K antagonists, but NOACs are preferred. That's a class 1A indication. And in patients who cannot have anticoagulation, we should consider left atrial appendage occluding devices in these patients. So the next thing is, how do we choose the best NOAC for a patient? It should, of course, be effective and safe from bleeding standpoint. We have to give special attention to patients with renal disease, coronary disease, elderly and frail patients, patients who have had bleeding in the past, and patients on certain concomitant medication. As far as the pivotal trials are concerned, we know that the RELY and ROCKET-AF and ARISTOTLE and ENGAGE-AF, they were the pivotal trials for dabigatran, rivaroxaban, apixaban, and edoxaban, respectively. And they all showed that the stroke risk is either same as warfarin or reduced in the same degree or more. So RELY 150 milligram twice a day was more effective than warfarin. Apixaban was more effective than warfarin. And rivaroxaban was non-inferior. But overall, we found that the NOACs are superior to warfarin in terms of efficacy, and this was mainly driven by this was mainly driven by a reduction in the hemorrhagic stroke. Ischemic strokes were not much altered except by dabigatran 150 milligram twice a day. The all-cause mortality was also slightly better with the NOACs. And this slide basically shows the same point, highlights the same point, that the benefit of NOACs was largely driven by a reduction, about 50% reduction in hemorrhagic stroke. And ischemic strokes were more or less similar or maybe slightly reduced. As far as bleeding is concerned, apixaban was found to be safest among all NOACs compared to heparin, as we can see in this slide. And this again shows the intracranial hemorrhage reduction with NOACs as compared to warfarin. So all the NOACs, they showed reduction in intracranial hemorrhage, but dabigatran and 150 and apixaban showed maximum reduction. And this again shows that there was a significant reduction, about 50% reduction in intracranial hemorrhage, while the GI bleeding was slightly increased with NOACs. Now, one important aspect of any anticoagulant is that we have to look at the elimination profile of anticoagulant, because accumulation of anticoagulant can cause bleeding. Now, as far as NOACs are concerned, it's very important to understand that dabigatran is largely cleared by the kidneys. About 80% clearance is by the kidneys, as compared to rivaroxaban, which is about 35% cleared by the kidneys. Apixaban seems to have the most diverse elimination profile, with only 27% eliminated by kidneys and 73% by the liver, and some directly excreted in the gut. And edoxaban is 50% eliminated by the renal route. So it is very important that we reduce the dose in patients who have renal dysfunction. So we look at two important points. One is eGFR of 50 ml per minute and eGFR of 30 ml per minute. Above 50, there is no concern. We can give anticoagulants in the normal dose. But below 50, in case of dabigatran, we must use a smaller dose. And rivaroxaban also, we must use a renal adjusted dose of 15 milligram per day. In case of apixaban, we have to have these three criteria of age 80 or more, weight 60 or less, and serum creatinine 1.5 milligram per deciliter or more. 2 out of 3 should be present to reduce the dose from 5 milligram to 2.5 milligram twice a day. Independent of this, if the creatinine clearance is less than 30, then also we use 2.5 milligram twice a day. And below 15 ml, the usage of any anticoagulant is somewhat controversial, because there are no robust studies showing clear benefit of any anticoagulant. So we have to individualize and of course shared decision making is most important in these patients. Now the GI risk is definitely GI bleed risk is a very real risk, and we have to be careful about that. And as we can see that the Aristotle trial showed that apixaban was slightly better, but non-inferior to vitamin K antagonists. But dabigatran 150 definitely had worse outcomes, and of course 60 milligram endoxaban also. Now, a very important subset of these atrial fibrillation patients is where the patient is undergoing PCI, or percutaneous coronary intervention. And we know that after coronary interventions, we are used to giving DAPT for a certain length of time, generally 6 months to 12 months. And patients in atrial fibrillation, they require anticoagulants. So that raises the dilemma that because if we combine the three, we give a dual antiplatelet and we combine it with anticoagulant, then the patient is susceptible to major bleeding. And we have seen that there is enough data, so very large data from Danish study involving more than 100,000 patients, which showed that if we give triple therapy, triple antithrombotic therapy, then the bleeding risk, major bleed risk is 10 to 13% per year. So that's unacceptable. So this is the slide showing the default dual antiplatelet therapy with the PCI, and different interventional cardiologists prefer 6 months or 12 months. And it also depends on the complexity of the lesion and also depends on individual preference. So there has been effort in the direction of giving only one antiplatelet combining with anticoagulant in post-PCI patients who require anticoagulation for atrial fibrillation. And several trials have been done. The WOOST trial was the first one which showed the benefit of giving a dual antithrombotic strategy combining anticoagulation with clopidogrel. And it showed that it reduces bleeding incidence without affecting the outcome. And the same was shown subsequently in case of rivaroxaban in the Pioneer PCI trial and dabigatran in Redual PCI trial. And this was a meta-analysis which was published from these three major trials, which showed that the bleeding is much less if we give dual therapy compared to triple therapy, and without affecting the ischemic events. So cardiovascular events were not impacted, but the bleeding risk is reduced by giving one antiplatelet along with the anticoagulant. And this was subsequently studied in a very good, elegant trial on apixaban, 2:2 factorial design, where the patients were given apixaban or warfarin, and also they were given aspirin or placebo. So the primary outcomes here were major clinically relevant bleeding through 6 months, and the secondary objective was to see if there is any adverse impact on the mortality or MI incidence or stent thrombosis incidence. And what we saw in Augustus trial was that the bleeding was significantly less in patients who were given, not only it was better with apixaban compared to warfarin, but also better with placebo in place of aspirin. So a dual therapy, dual antithrombotic strategy was superior to triple therapy in terms of bleeding. And it was similar in terms of any thrombotic or ischemic events. So we found similar curve and there was no adverse effect. So the latest guidelines for PCI patients who undergo atrial fibrillation, they mandate that DOACs are preferred over vitamin K antagonists. And for most patients with atrial fibrillation who undergo PCI, we can give aspirin only for 1 to 4 weeks. And subsequently, we can switch to dual antithrombotic therapy with oral anticoagulation and P2Y12 inhibitor. Generally, clopidogrel was used in most of the trials, but one can use other P2Y12 inhibitors also. The trials are going on and the data is accumulating. Now, one important aspect is patients who have a bleeding tendency, particularly GI bleed, etc. So it is important to understand that we, as far as possible, we try not to withhold anticoagulants in these patients because the stroke risk is much higher compared to bleeding risk. So we should instead try to find out the reasons for bleeding, and we should look at various risk factors which may make the patient vulnerable to bleeding and try to mitigate those factors rather than withholding anticoagulants. And again, we go back to the same point that we should select the agent which has shown the least GI bleeding. And here I can say that edoxaban 30 or apixaban, they score highest marks, highest points as far as safety is concerned, safety from GI bleeding is concerned. And rivaroxaban and dabigatran 150 are not so good. So apixaban scores very well here in terms of safety from GI bleeding. A very recent study, it has been on the device-detected atrial fibrillation. There are a couple of trials have been published. One is NOIF NET6 trial, and one is the Artesia trial. Because in many patients with the pacemakers and defibrillators, we see that they have arrhythmia on the monitor, and the significance of that was not very well known. So NOIF trial showed that if giving anticoagulant for patients who have 5 minutes to 24 hours arrhythmia burden was not very beneficial, but it increased the bleeding incidence. On the other hand, the Artesia trial showed that if we give anticoagulant to these patients, they had less incidence of stroke or systemic embolism, but they also have a slightly higher risk of major bleeding. So this is something that is in evolution. But the latest guidelines on the basis of these trials have shown that if the atrial high rate episodes last more than 24 hours, then we should give anticoagulant. That's a class 2A indication, so it's reasonable to use them. But patients who have between 5 minutes and 24 hours, they may be considered, but it's not, the evidence is not sufficient to recommend them. And patients who have very occasional less than 5 minutes episode, we should not use anticoagulants. So this is my last slide, which summarizes these points. So if the patient has recurrent stroke or patient has stroke while on anticoagulants, we can consider switching to the regimen which has shown the maximum efficacy, that is dabigatran 150 milligram twice a day, provided the patient has no contraindication, that renal dysfunction, etc. If the patient has moderate to severe renal impairment, then of course apixaban is the logical choice because it has minimum renal clearance. If the patient has high risk of GI bleeding, then again apixaban is probably the best choice. Otherwise, we can use dabigatran 110 milligram, although that can cause some dyspepsia, etc. If the patient has GI symptoms or dyspepsia, then we again use apixaban or rivaroxaban or redoxaban, because dabigatran is one culprit here. Patients who have high risk of bleeding, we can either use dabigatran 110 or apixaban is a safer choice. And patients who prefer once a day dose, then of course rivaroxaban or vitamin K antagonist or edoxaban are the choice agents. So I think I will stop here. There should be many questions about anticoagulants, such a vast topic, but I will stop here and take if there is any question. Thank you so much. Thank you for listening.
Thank you. Thank you very much for your nice deliberation, sir. Thank you very much for taking us to the evidence-based use of use in specifically SPAF. Now, doctors, we will learn about the expert use. We will hear from our today's experts how they manage such patients in their specific country. She is Dr. Anumali Vidana Gamagi. She is a neurologist, consultant neurologist from Sri Lanka. She is an associate secretary of Sri Lanka Stroke Association. She is also a council member of Association of Sri Lanka Neurologists and Movement Disorder Society. She has done her training in neurology and stroke at St. George University Hospital from London. She has been also awarded with a prestigious award called Dr. P.T. De Silva Gold Medal in Clinic Medicines in 2018 in Colombo. She has done local training in Institute of Neurology in National Hospital of Colombo as well, and presented several international forums, contributed to few journal articles related to neurology. So I welcome Dr. Anumali. So, and I request to share your perspective in managing the patients suffering from AFib and the prevention of stroke. Over to you, Dr. Anumali.
Thank you very much, Divyanshu, and thank you all for inviting me to this forum and to talk. Sri Lankan perspective of stroke management. I would first give a brief introduction how Sri Lankan health system works. So it's currently mainly a free health system, majority. So Sri Lanka is a relatively smaller island with 9 provinces and 25 districts. So the stroke care is mainly based on the government health system. And can you hear me?
Yeah, you are audible, ma'am, clearly.
Okay. We have 35 thrombolysis centers in the country. So we have mainly 2 national hospitals and provincial general hospitals and district hospitals and base hospitals. So this is the setup usually. So almost all district general hospitals have stroke thrombolysis facility. So that is for hyperacute stroke management. And so the people, the general public, and there is a private sector as well, so driven by individual doctor practices, GP practices, and private hospitals, which are relatively limited and mostly centered in the cities. So the stroke patients, they usually come to the primary care setting, which are mainly the hospitals. So detection of atrial fibrillation in stroke is mainly a clinical diagnosis at the moment. So mainly during routine examination of pulse and a 12-lead ECG, usually with this rhythm strip. And then as for routine stroke screening, we recommend for a 2D echocardiogram and a cardiac Holter monitoring in most of the patients. So this is how we pick atrial fibrillation. So once atrial fibrillation is detected in stroke in Sri Lanka, so I mentioned that currently the general health system is mainly a government-driven system. So it's a free health system. So currently, the economical constraints are the main reason, the barrier to introduce NOAC. So NOAC is not in the government formulary. It is included. 2 NOACs are there, but not to be freely given to patients in majority of the hospitals. So it's a main limitation in Sri Lanka. So warfarin is the main anticoagulant we use at the moment. However, so for affordable patients, we do offer NOAC. So mostly we use dabigatran, rivaroxaban, and apixaban in Sri Lankan setup. So you may be aware of the limitations of using NOAC, especially even though it reduces the recurrent stroke risk or stroke risk overall. If a patient comes with a stroke while on NOAC, so thrombolysis within 24 to 48 hours of the last dose is a limitation. So where we offer for thrombectomy in such cases. So usually the hyperacute stroke management is in Sri Lanka is thrombolysis. And we have thrombectomy only in a few centers, mainly in Colombo and National Hospital Kennedy, in 2 or 3 stations. So that is again a limitation in use of NOAC. So I would like to highlight the 2 aspects, the overall economical constraints, where it is not included in the provisions of free health service, where the patients have to afford for NOAC, and the reduced availability of mechanical thrombectomy, hyperacute stroke management are the limitations, but we do use NOAC for patients who are affordable to take.
Thank you very much, ma'am, for giving your perspective in management of SPAF. So now I request Dr. Al Mahmood. Before that, I will like to introduce Dr. Al Mahmood from Sri Lanka. From South Africa, I'm sorry. So Dr. Al Mahmood is a cardiologist from South Africa. His main interest is in structural and interventional cardiology, including complex PCI, TAVI, and CTO, and device therapy. He has worked for more than 18 months at Grootschuur Hospital and is passionate about teaching patient care and holistic approach in managing CVD. One of his strengths is excellent procedural techniques with a deep understanding of all interventional tools needed to complete a case, keeping the risk of complications as low as it can be. Taking his clinical skills and linking them with an imaging and procedural findings, which makes diagnosis and management of CVD a joyful experience with excellent patient outcomes. He has done various publications like an apical approach for pericardiocentesis, and he was a part of HF study as well. So I welcome Dr. Al-Naili Mahmood and I request him to give his perspective in managing such patient in South Africa.
Thank you very much for the kind introduction. And I also thank your speaker for his comprehensive review of the topic. From South African standpoint, it's not really far away from what's going on in India and also in Sri Lanka. And we do have a health system that is based both on state sector and a private sector. So I've had the luxury of working in both. And it's really a matter of reimbursement. So from a obviously warfarin is present in both the private and the state sector, but for novel oral anticoagulants, it's all present in predominantly in private for reimbursement issues. But luckily, we do run some studies, and we managed to put quite a large people population in state hospitals under NOAC, predominantly rivaroxaban. So I would like to touch, I mean, that's from the geographical and from private state hospital point of view. In terms of screening, we do have, the community health centers that are equipped with, I think, in my point of view, all the necessary tools to diagnose atrial fibrillation and to refer timeously to our referring centers. So I'm based in the Western Cape in Cape Town, and we do stroke interventions, and I personally do it myself. So we follow a very robust ambulance system that does send patients, especially in private sector, to the PCI capable hospitals, as some cardiologists in South Africa do practice stroke intervention. And from a NOAC prescribing standpoint, and from my background as structural intervention, I do left atrial appendage occluder devices. And I must, if I had to add a comment, if you can put your patient on a NOAC, probably it's better than sending him for a LAA occluder unless you have no choice. And the reason for that is this procedure is very complex. I'm not doubting the success for the procedure. It is somehow successful, but it is very, very labor intensive and subjecting your patient to various lists of complications. And if you manage to put them on a NOAC, that will probably be the first prize. But obviously, if you visited all the avenues of working him up for the risk of bleeding and went for C-scope, G-scope, and you done what you can do in terms of mitigating the bleeding risk, and the patient is still losing blood via the gut, then then you have no choice, unless you have no choice putting in a plug to lower the risk. And as it's stated in the talk and also the guidelines, it's not a class 1 indication. So that's something very important to emphasize on. So we do those plugs all the time, but only in very selected patients where the workup and the NOAC is keeping the patient quite anemic and there's bleeding ongoing. The one last thing that I also want to touch on is in the age group on which you start the NOACs, and obviously for every age group there's a limitation on the dosage and the type of NOAC that you use. So after age 75, for example, there's quite a bit of limitation in the dosages, for example, with rivaroxaban. And the speaker did allude into that as well. So that's something very important to bear in mind, as well as the glomerular filtration rate. So renal function is important to look at before you prescribe the NOAC. Other than that, I think most of the speaker was very outstanding in covering the topic, and I can pass the ball now to the next panelist. Thank you.
Thank you so much, sir, for the informations and giving your perspective in management of AFib and stroke prevention. So with us, we have our last but not least, the expert panel is from Philippines. He is Dr. Michael Joseph Agbayani from Philippines. He is a cardiologist. He is an He has done his electrophysiology fellowship from Philippine Heart Center and National University Heart Center from Singapore. He is a head of a Philippine General Hospital Central ECG Station. He is also a council chair, Council of Electrophysiology and Pacing from Philippine Heart Association as well. He was a formal council chair from the Council of Heart Failure Philippine Heart Association. He is a training officer from Division of Electrophysiology from Philippine Heart Center. He is also a board member of Philippine Heart Rhythm Society as well, and he is a consultant at Medical Center Manila from Manila Doctors Hospitals in Philippine Heart Center. So I welcome Dr. Michael once again, and I request him to share his own perspective in managing such patients.
Thank you. Thank you everyone for inviting me as a reactor, sir. And thank you to our esteemed speaker, Dr. Saxena, for an excellent summary. Thank you, Dr. Anomaly and Dr. Mahmood, for sharing their experiences in Sri Lanka and South Africa. Well, in the Philippines, I think it's slightly different from Sri Lanka and South Africa. Everything is out of pocket. This is very, very minimal coverage from our government. So I would say about 90% would be out of pocket. So actually, we want to prevent strokes as much as possible because if you have a stroke here in the Philippines, it would be very, very expensive. Most specialists and most specialty hospitals that can handle a really bad stroke are in the city centers, same as Sri Lanka. And a lot of the problems are economic. So a lot of my patients, they actually ask me if there are any alternatives to uh, anticoagulation. And in fact, a lot of patients, when they come to me, they're actually on antiplatelets. Okay? So actually, this is one of the probably topics that I need to look at here in the Philippines. But I think antiplatelet use is still common. For when primary care physician sees atrial fibrillation in a patient here, um, not knowing that it's we prefer to anticoagulate the patient. We prefer to use a NOAC in patients with non-valvular atrial fibrillation. Um, um, Here in the Philippines, it's basically specialist driven, meaning once a patient gets diagnosed with atrial fibrillation, once the patient has symptoms of atrial fibrillation, they actually go directly to a cardiologist. So they're not being seen by primary care physicians. So which is the reason why when primary care physicians see these patients, they're not as confident prescribing NOACs. In fact, there's a tendency to underdose patients on anticoagulate. They usually go for the lower dose. Okay, so it's either they go thinking that it might help, go with an antiplatelet like aspirin or clopidogrel, or they go with the lower dose. For example, if you're going to give rivaroxaban, they're going to give 15 milligrams, apixaban 2.5 twice a day. So this, regardless of the age, the weight, and the kidney function. Okay, so this is an interesting thing to look at, whether underdosing is actually helping or harming these patients. So this is something that is I think prevalent in Southeast Asia, and I've spoken to colleagues from other Southeast Asian countries, and there's a tendency to underdose because they think that Southeast Asians are actually are bleeders, meaning that they have a tendency to have a higher gastrointestinal bleeding rate than our Caucasian counterparts. So, um, and I think we have a lot more, especially in the Philippines, we have a lot of rheumatic valvular heart disease patients. So that would mean that we're also using a lot of warfarin still, because I guess the Invictus trial showed us that NOACs might not be the best medication for in patients with rheumatic valvular heart disease, but because of our economic status and because how prevalent rheumatic fever is in the Philippines, we still have a lot of rheumatic valvular heart disease patients. So warfarin is still being used here for stroke prevention in patients with atrial fibrillation. As for the left atrial appendage occlusion devices, we have some cases, but I think it's too expensive for more widespread use, even for patients who have contraindications to anticoagulation. Most of our patients here won't be able to afford an occlusion device, so that actually limits our options. But I guess here in the Philippines, we really want to prevent strokes, because once we have a stroke, it's going to be very expensive. This is what I tell my patients. This particular medications and anticoagulants, we really have to be on them, and not to be too scared of gastrointestinal bleeding, because gastrointestinal bleeding will be just a trip to the hospital, at most maybe transfusion. But once you have a stroke, that would be very, very expensive, very debilitating, and possibly fatal outcome. So I guess for the Philippines, that's it. It's mostly economic. The issue is mostly economic.
Thanks a lot, Dr. Michael, for sharing your experience and clinically managing such patients. As you said, that mostly economically, people are not able to afford after stroke, and that's why prevention of stroke is very, very important in your country. So thank you. I thanks all the expert panelists and our today's speaker for their talk. And now we are open for Q&A, and we'll take some of very interesting questions, starting with a question related to the screening. So nowadays, doctor, you are aware that many point of care devices and portable ECG machines are available for screening of AFib, like let's say Apple Watches or Cardia Mobile 6L devices. So using such devices, do you make your clinical decisions if the AFib has been detected? So what's your perspective on that? Can we have answer from first? We'll start with Dr. Anil Saxena, sir.
Yeah, hi. So I
Yeah.
think it's a very relevant question, very relevant point, because the next important thing in prevention of stroke is the screening for atrial fibrillation, because as I said in the beginning, the risk of stroke is evenly distributed in silent and asymptomatic patients. So it's very important beyond a certain age, just like we investigate the patients, or when a patient comes to us in the clinic, we look at blood pressure, we look at diabetes, we look at high cholesterol. We try to figure out whether patient has any risk factors or not. In the same manner, beyond a certain age, we should also look at the sinus rhythm, at the ECG, whether patient has sinus rhythm or not, or whether patient has atrial fibrillation or not. So wearables are going to be very important modality in future for detection of atrial fibrillation. At the moment, they sometimes create more confusion because many patients are being overdiagnosed. Sometimes it's just signal noise. Sometimes it's very small episodes which are picked up by the device, and then the patients get worried unnecessarily. So we are in as far as surveillance is concerned, we are in evolution. So it is very important at the moment to have, whenever there is any device detected episode of atrial fibrillation, we must look at actual ECG, whether by screening by the routine ECG or by some long-term ECG recorder like a ELR. We can do a 3-day or a 7-day ELR and look at whether the patient is having episodes or not. And these devices like Cardia, etc., are quite helpful. That's what we have seen in the EP circles, that these devices are very helpful because they record actual ECG. And even among the wearables, there are some devices which use what we call PPG technology or plethysmography technology, which doesn't give a correct assessment of rhythm. But the Apple Watch, etc., they have actual ECG recording, and we can utilize them to detect atrial fibrillation. So it's very important that the device actually records ECG and not uses a photoplethysmographic method to demonstrate the rhythm or diagnose the rhythm.
Thank you, sir. Thank you. I request Dr. Mahmood to share your perspective. Okay, he is already carrying a device, Cardia Mobile 6L. So please
Yeah,
share your opinion
so
on.
I'm not advertising the device, but I just find it very useful in those patients. Whenever one comes in with an Apple Watch, as Dr. Saxena has indicated, I just throw this at. So I give them this device, and it's a 6-lead recorder, and you just place it 2 thumbs, and this part goes onto your ankle when you sit with crossed leg, and it gives you a very nice ECG tracing, and it really answers the question. You know, some patients keep it for a week, some people keep it for a month, some of them never bring it back. But I mean, at least from my perspective, in my rooms, when patients come and visit me here, they do have an access to this device. I think it's probably $150 per device. So either patients leave a deposit and they take it home with, and bring it back and claim that deposit back, and we just reuse it in that manner. And I find it, I mean, if they can afford an Apple Watch, my argument is always they can afford this device. So I just give it out like that, and it's a nice tech to use with the cell phone. If I don't see it's subclinical and I don't see it's actually even warrants a Holter device or an ILR, as Dr. Sexton. But I do find this very useful. It's very cheap. Obviously, having a Holter device is more expensive. And I mean, we can talk about screening for a very long time. It's a very complicated topic. But I mean, I'm going to just put my foot down here. At this stage, I think we're still at the 12th lead ECG to make the AF diagnosis. I mean, we sat together early this month in a CASA meeting in Johannesburg, and that's still the feeling, very strong. Get a 12th lead ECG. I mean, from GPs, from medical officers, that's where we still at. I mean, following all these devices can be very confusing, and you're going to pick up a lot of noise, and it's exactly the same message. Thanks.
Thank you. Thank you for sharing your perspective. Now we'll take another questions, and we'll take the help of Dr. Anumali and Dr. Michael for the same. So, sir, ma'am, when we talk about the safety and efficacy data of the landmark trials of NOAC, and then we compare it with the real world evidences, then we have seen almost the efficacy outcomes is higher as compared to the landmark trials, as well as the bleeding events is lesser as compared to the landmark trials in real world evidences. So what do you found similar in your clinical practice? What is your opinion on the same? Yes, Dr. Anomali, madam. You are mute, ma'am.
Yeah. So yes, you're correct. And so actually, I would like to mention my practice experience in UK rather than in Sri Lanka. So I have not a very large cohort of patients who are using WAC, but in UK it does. Yeah, bleeding risks are relatively very much less. We've never had the time I was there. But then the only complication I mentioned was efficacy-wise with certain NOACs getting strokes while on NOAC. But yes, you're correct. And it is very much easy to use and efficacious in practice. And yes, we recommend almost all if the patient is a suitable candidate for a NOAC. Yes.
Thank you.
And
Thank
Dr.
you.
Mike.
Yes. So Dr. Michael,
Yeah,
can you just share that what could be the reason behind the same? Whether we are not able, we are not able to diagnose the bleeding as such with the NOx, because in landmark trials everything is controlled, and it has been patient has been looked for the active bleeding, and in real world clinical practice as such, we don't look for such bleeding. So that may be the reason.
it's
What's your
yeah.
opinion?
Yeah, it's possible for the real world, a lot of these patients don't go to the hospital or might not be even able to recall the non-clinical bleeding or the smaller bleeds that they have. So of course, you're much more able to detect like severe bleeds, gastrointestinal bleeds that will result in a drop in hemoglobin. You'll need to be hospitalized. Um, and I think we also have to look at like the CHADS-VAS score, because we saw in studies that CHADS-VAS scores, if you have a higher CHADS-VAS score, the higher your risk for bleeding. It means your HAS-BLED score will be
Yes.
higher, so you have a higher risk of bleeding. So for the trials, they actually made it a point that they recruited like very high risk patients or high risk for stroke. So maybe in the general population, maybe the risk for stroke might be the CHADS-VAS scores might be a bit lower than the study populations. So that means that they're a lower risk of gastrointestinal bleeding. I've seen this in my private practice as well. That I rarely see any bleeds. I mean, major bleeds from NOACs.
Thank you, Sasim. Thank you very much. So before we conclude, doctors, I just request all the participants as well as panelists as a speaker that we have a structured one survey, online survey on the use of NOACs in their clinical practice. The questions are structured related to its efficacy, its safety, and related to the patient compliance. So I request all the participants, doctors, to just fill the survey, which is available while you registered while using the registration link, or during you put your questions in the Q&A section. So below that, take a survey, there is one option. So my request is that all the participants, doctors, as well as panelists and the speaker just have that survey on the same. Otherwise, it was a very wonderful session, and having especially Dr. Anil Saxena and all the expert panelists from different countries, Dr. Anumali, Dr. Michael, and Dr. Mohammed. Thank you very much. And I will just give Mr. Sanjay to give vote of thanks.
Yeah, thank you so much to all the esteemed doctors joining across as a panelist as well as a audience who have joined. So as it has been said that heart is communicated with the brain by sending more signals to the brain, and simultaneously brain send a signal to the heart. And this bidirectional connection is known as heart-brain connect. Similar fashion, Zydus is also connected to doctors in a bidirectional way, both by brain as well as by heart. Zydus, we always say that we are dedicated to life. Today, we are saying that because we will try to offer all the possible option when we are managing a disease related to brain or it's related to heart. Today, we have almost clock 350 plus participant all the way from Africa, where it is early morning, and all the way to Philippines. And almost 500 registration we have seen. And though it's a totally a different time zone. Thank you so much for joining today's discussion. I wish to have many such session in coming days as well. And thanks to all my local team who made this possible today. Thank you so much. Have a good day to all. Thank you.
Thank you so much. Thank you. Thank
Thank,
you.
thank you very much. Thank you.
We are offline.
Yeah. Thank you, doctors.